Hi, and welcome to today's lecture on RNA viruses. Last time we talked about DNA viruses, today we're talking about RNA viruses. So our quote here is from last year, almost a full year ago, April 24th of last year, when the CDC reported a case of 695 cases of measles in 22 states. There had been outbreaks in 2018 and a few here and there, but it's hard to believe now, but measles had been eradicated or eliminated from the United States in the year 2000. And in the last 20 years, we've seen recurrence of measles over and over again, which is sad because it is an entirely vaccine preventable disease. It's also one of the most rapidly spread diseases, not one of it, is the most rapidly spread disease that we have around today. So we're going to talk about measles today. We're also going to talk about rhinovirus, respiratory syncytial virus, rubella, and hepatitis C. So here's our case study for today, all right? So this is a real case. In February 2012, an infant was born at 36 weeks gestation, weighing just 4.2 pounds, and was noted to have congenital heart defects, hyperpigmented skin lesions, which you can see down here, cataracts on her eyes, cerebral edema, and pericardial effusion. Hearing impairment was suspected after the infant failed a hearing screen, and bilateral profound hearing impairment was diagnosed by an audiologist in June. Surgical procedures for correction of congenital heart defects and cataracts were performed. During eye surgery, the infant experienced breathing difficulties and went into cardiac arrest. Following stabilization, the infant was admitted to the pediatric ICU for observation and was later discharged. So the questions I have, you can pause here and think about these two. Which vaccine preventable viruses are you aware of? And which of those do you know of that can cause fetal or neonatal infections? So in our DNA viruses talk, we learned a little bit about some DNA viruses that can cause fetal and neonatal infections. Some of the symptoms here may be the same, some of them may be different. So do you think it's one of those, or do you think it's something else? Think about those for a few minutes and then come back. All right, learning objectives today. Explain transmission and the respiratory involvement of rhinovirus. Describe the structure, transmission, CPE, and symptoms of respiratory syncytial virus. Differentiate between measles and rubella based on clinical descriptions. Differentiate between measles and rubella based on virus morphology and characteristics. Identify individuals at risk for developing severe complications of measles and rubella and what those complications could include. Explain the importance of vaccination against measles and rubella childhood diseases, and describe the differences in acute and chronic hepatitis C infection, as well as diagnostics and treatment. All right, so let's start with the rhinoviruses. These belong to the family Picornaviridae, so they are a picornavirus, and there are a little more than 100 different serotypes, meaning there are about 100 different strains of rhinoviruses. So they have a naked icosahedral capsid. They're pretty small, which we can see over here. And they have a positive sense single-stranded RNA genome. So they belong to Baltimore class 4. These are responsible for causing the common cold. So anytime you just have a cold and you feel a little bad and you don't go to the doctor and you get better on your own in a few days, you've had a rhinovirus most likely. These are limited to the upper respiratory tract. And that's due to temperature. So these viruses do not replicate well at the warmer temperatures of the deeper lungs. So they replicate there in the upper respiratory tract where the temperature is actually a little bit cooler. They are highly infectious. So you only really need to inhale one virion, one single virus, to become infected with a rhinovirus, which is why, if you think about it, you know, even just like a month ago, half of you guys were all getting some sort of cold because you were sharing the same space. And there was probably a rhinovirus going around and everyone had a cough or a sniffle or a sneeze. These are transmitted by aerosols. So anytime you cough or sneeze or expectorate when you're talking, and also by fomites. So aerosolized droplets that land on a desk, and then you touch your desk and you wipe your nose or you touch your mouth and you get the virus on yourself. They can also be hand to hand, right? So people who cough into their hands don't wash their hands and then shake hands with someone else. I've been saying for years we should stop shaking hands with people. But direct contact is the most common. So someone is breathing on you, coughing on you, sneezing on you, or in your general direction, and you inhale those particles. Now we do get from the rhinoviruses some partial or incomplete immunity. So even though we don't get full coverage to each serotype we're infected with, we do get some immunity. And this is why we see that the number of colds a person experiences decreases with age. So you think about little kids, particularly in daycare, they always have some sort of cold or another, a cough, a sneeze, a runny nose. And as children age, and start into elementary school, the number of those colds decreases. And now as a grown adult, you have less and less because you've built up a variety of partial and incomplete immunity so that you can deal with these coronaviruses more easily when you see them. Unfortunately, like with a lot of viruses, there's no specific treatment. For the most part, that's okay for rhinoviruses. You guys all know you've had a cold, you feel bad for 2-3 days, and you get better. So even if there was a specific treatment, it might not even be one that's worth prescribing and spending the money on because you're going to recover on your own. Right, so rhinoviruses, there's a lot of that going around right now. A respiratory virus that's a bigger deal that causes more severe effects is respiratory syncytial virus. So you've probably heard of this particular virus. It belongs to the family Paramyxoviridae, and it is a negative sense single-stranded RNA virus. So it's Baltimore class 5. So here's a little diagram of our virus. Here it is with its helical capsid around its negative sense single-stranded RNA. It then does have an envelope surrounding the whole thing, and a number of glycoproteins coming outside of that envelope. So there's the attachment protein, there's a fusion protein that's going to allow membrane fusion, and then the proteins inside that make up the helical capsid. So its name comes from its ability to form syncytia, both in vitro, so in cell culture in the lab, as well as in vivo during the body. So syncytia are a form of CPE where membranes of neighboring cells fuse together because they're expressing these fusion proteins from the virus. And as they fuse together, they make these giant multinucleated cells. So our arrow is pointing at one here, and I'm kind of tracing it around. All of these pink spots within are nuclei, and we can see this enormous, huge cell here compared to, say, a single cell over here. So it infects the respiratory tract, and it causes these huge syncytia, which gives us its name, respiratory syncytial virus. So again, this disease is limited to the respiratory tract. It doesn't really cause any other set of symptoms. And usually it's the upper respiratory tract that is involved. Occasionally it can be the lower respiratory tract, but like a lot of viruses, it's usually in the upper respiratory tract. Transmission for this one, again, fomites. So someone coughing or expectorating or sneezing on something, that then being touched. Hands, right? So if you are a caregiver who has RSV, you can give it to a little baby by touching them from your hands. And of course, respiratory droplets. So expectoration, sneezing, coughing, very wet, heavy exhaling or inhaling. One of the issues with RSV is nosocomial spread. So if you are taking a young child to the doctor's office and you're sitting in the waiting room with a parent or another child who has RSV, it can spread really easily there in the waiting room. So some children actually pick it up in the waiting room while they're at the doctor's office for another problem. It can also spread through hospitals, through NICUs if people are not following certain precautions. And it's thought that anywhere between 65 to 98% of infants in daycares will be infected with RSV by age 3. My son had it at around 2 years of age, and he picked it up from his daycare. I think there were 3 reported cases in his small daycare class at that time. So it's really common for it to spread around in daycares. Its clinical manifestation is mostly difficulty breathing, so labored breathing, along with cough and sometimes wheezing. In more severe cases, this can cause very bad respiratory distress, like gasping for air, and in the worst cases, cyanosis. So the young child will look like they're starting to turn blue, and that's particularly evident on the lips. So the lips will start to turn blue. So when my son had it, he had a really bad cough. He was coughing so hard that he would occasionally vomit, and he was wheezing for breath. It was really, really terrible. It can be fatal in infants and in young children. So particularly in preemies. So sometimes you'll see little babies in their stroller, in their car seat, and they'll have a tag hung on them that says, preemie, please don't touch RSV risk, something like that, because of the cyanosis that can occur and the decrease in blood oxygen levels. In older children and in adults, if they acquire RSV, it may be asymptomatic or generally just a mild cold. And these two things, an asymptomatic person or someone who has a mild cold they're not concerned about, can be a problem when someone like this is a caregiver for an infant or a toddler, if they unknowingly pass RSV on to that susceptible population. Okay, we can diagnose RSV through RT-PCR testing of a swab. This is the most reliable. It's not super fast, right? You have to send it out and you get results, depending on where you are, anywhere from 24 to 3 days later. There is an antigen detection swab, so a sort of rapid test. It is specific, but it's not that sensitive. So it can come back as a negative, and a PCR test will be done just in case. Like with most viruses, treatment, usually it's self-limited. Unfortunately, RSV can persist for about 6 weeks. My son was not sick for that long, but that's a very long time to watch a young child cough and have trouble breathing. But as you guys know, antivirals are not that common, and because antivirals are so super specific, there's not really a great one against RSV. In severe cases where extra care is needed, it's just supportive care. So coughing dehydrates you, and in babies who are coughing a lot, they can become dehydrated really easily. So hydration either through pushing extra bottles, it could be intravenous if it's very, very severe. In those really severe cases, a child may become hypoxic, and you'll want to give oxygen by nasal cannula or a face mask or something like that. The best thing to do is to prevent. RSV is highly contagious. It can spread very, very quickly. Those preemies are at the highest risk because they can develop other issues as well. So this little infographic that I pulled here is just kind of what we will tell parents about RSV, about preventing RSV, about how common it is. All right. Okay, measles virus. Everyone has heard of the measles. Like RSV, it also belongs to the family Paramyxoviridae. This one belongs to the genus Morbillivirus. It is a negative sense single-stranded RNA enveloped virus. It belongs to Baltimore class 5. And here we see its genome with its helical capsid, and it is surrounded by this envelope. It's kind of a weird diagram. On the outside, it has two main proteins, hemagglutinin and the fusion envelope proteins, and it attaches to the cellular receptor CD46, which you've probably heard of. When we think of measles, we think about the rash, like the typical red rash that measles causes. But unlike, say, chickenpox, which can be spread by touch, measles is spread through inhalation of droplets. Because it's spread by respiratory droplets, that's why it is so highly contagious. It's the most contagious disease we know of today. The R0, if you know that term, the R0 for measles virus is about 18. The R0 for the current coronavirus outbreak, which is spreading really quickly, right? So the R0 for COVID-19 is 2.5, if that tells you anything about how contagious measles is. Here's an electron micrograph of it. You can see it's enveloped, it's pleomorphic like most enveloped viruses, and here on the outside are all its little hemagglutinin and fusion protein spikes. Okay, so measles, excuse me, has a relatively long incubation period. It can last anywhere from about 10 to 14 days. Okay, so in that time, the virus gets in, it begins replicating, and our first set of prodromal symptoms are respiratory symptoms, and the formation of these things called Koplik spots, which I have a picture of it for you here in a little bit. So there in the respiratory tract, syncytia are forming, like we see with RSV, and this leads to necrosis and inflammation there in the respiratory tract. So it appears as like a mild cold, a little bit of difficulty breathing, but at this point, nothing super severe that you wouldn't think is normal for a young child. However, as this inflammation is occurring, we get the recruitment of T and B lymphocytes to the lungs. The virus then infects those cells and spreads from the lungs throughout the body. All right, so if we look at our time here in our prodromal phase, we have our respiratory symptoms, our Koplik spots. Infectious virus is beginning to be present here. And then after a few days of that, the characteristic rash develops. So this is what we think of when we think of measles as the rash. So while these T and B lymphocytes are infected and the virus is spreading through the body, as we talked about with viral pathogenesis, measles results in the decrease of IL-12 production. So we have, we skew the immune response to not be more toward our CD8 cells, but be more antibody mediated. And because we don't having as good an immune response, our patients are susceptible to superinfection with other viruses or with a variety of bacteria. Eventually, the antibody response will clear the virus. So it comes up nice and strong. We will clear the virus. Symptoms will desist after about 7 days of that rash. And our immune response to this is so strong that you develop lifelong immunity. All right, so a person who got measles as a child won't get it again as an adult. So that is good. Unfortunately, measles can be fatal either immediately during the acute phase of disease, or because that can result in this chronic infection called subacute sclerosing panencephalitis. All right, we often hear, and we heard this during the 2019 outbreak, people saying, oh, measles is just a mild childhood disease. Well, I don't really need to worry. Then my kid's going to recover and be just fine, which is not the case. 1 in 20 children develop pneumonia due to measles infection, and this is the leading cause of death due to measles infection. 1 in 20. That's a pretty high percentage for a mild childhood disease. 1 in 1,000 patients develop encephalitis. Measles encephalitis can lead to convulsions. It can leave the child permanently deaf, and it can result in mental disability to the children. I would not take that chance. 1 in 1,000, I'm not taking a 1 in 1,000 chance. 1 to 2 in 1,000 patients die of measles, whether they develop these or not. And then, of course, there's the potential for subacute sclerosing panencephalitis. This usually occurs years after initial infection, but it is a fatal disease. There is no treatment and no cure for it. And again, measles is really, really highly contagious. It's the most contagious disease that we know of. So if we just look at the number of cases per year, right? So back in 2000, there were no cases. Measles was considered eliminated from the United States. In 2010, we had 63 cases. We had a bump. We went back down. In 2014, we had 667 cases. And it seems like after that, people kind of got wary and the numbers went back down. But then in 2018, we had an outbreak. And in 2019, and this data, if you look, this data was collected in March of 2019. We were at 387 cases. 1 month later, when the quote that started off this slide set was taken, April 24th, that number had jumped up to 694, I believe it was. So in a month, we saw a doubling of that in 2019. Interestingly enough, a lot of those cases were linked to people visiting Disney. Okay, so diagnosis, treatment, and prevention. Of course, we all know the best prevention, but let's talk about diagnosis first. The symptoms of measles, if you know your patient is not vaccinated, the symptoms alone are diagnostic. One of the things, especially if it's early on, that you'll look for is what are called complex spots. So these are white, you can see them, the one the arrows are pointed at are actually not that great. You can kind of see them behind them. There are these white dots surrounded by a red ring on the oral mucosa, so on the inside of the cheek. So you'll see these complex spots. Those are indicative of measles. That, and they are sometimes concurrently, you'll have these complex spots along with a rash. And for measles, the rash starts at the head and moves down the trunk, right? So with all these rashes, the place where they start, the place where they appear, is a really differentiating sign. So this one starts at the head, moves down the trunk on the chest and on the back. Along with those two things, our patient will also be experiencing cough, right? Because remember, it causes syncytia in the upper respiratory tract. They can have runny noses, they can have conjunctivitis, and generally a fever, okay? So taken together, these symptoms don't sound too bad, but when you consider the 1 in 20 chance of pneumonia and the 1 in 1,000 chance of severe complications like encephalitis, it's not a mild childhood disease. Okay, so if we can diagnose it based on symptoms, we can also do real-time PCR. We can do serology to look for antibodies against measles to confirm our diagnosis. So things are challenging with measles because there's not a treatment for it. There's no antiviral. So if you have a person, a patient who is developing complications, we don't have a drug to get rid of the virus in the body. The only treatment we can offer is supportive. So providing fluids, if fluids are needed, pain relief, things like that. And then if our patient is developing super infections, secondary infections like a bacterial pneumonia, we can treat those secondary infections, but there's nothing we can do to get rid of and to treat measles itself. You all know there is a vaccine. It is a live attenuated vaccine. It's part of the quadrivalent measles, mumps, rubella, and varicella vaccine, the MMRV. It used to just be MMR. It's a really good vaccine. Again, one of the issues with vaccines are timing. So this vaccine, the first dose is given somewhere between 12 and 15 months. So imagine those children who are younger than 1 year have not been vaccinated, and if they are exposed to an older sibling who has measles, they themselves will likely are going to develop it. The vaccine's also safe in adults. So if you have an adult who has not received their MMRV vaccine, you can give it to them, it's fine. But you don't want to give it to the immunocompromised patients, and you don't want to give it to pregnant women. Because it's live attenuated in immunocompetent people, it replicates a little bit, but it doesn't cause disease. And that replication is good. I believe you guys are talking about vaccines and immunology this week. That replication is good because it stimulates a really robust immune response. But in the immunocompromised, they can't control replication of that attenuated vaccine, so it can actually have some issues there. Also, it's the same in pregnant women whose immune systems are depressed somewhat, so it's not necessarily safe to give to them for those same reasons. It can't control replication of these attenuated viruses well. Okay, so we're about halfway through. This is a good time to take a break before we start talking about another virus. So take a break, get up, go walk around, take a picture of your pet and email it to me. I want to see who you guys are hanging out with while you're here on break. All right, take a break, come back in a few minutes. And we're going to talk about Rubella virus. This is another part of the MMRV vaccine, Rubella. It's different though. This one belongs to the Togaviridae, genus Rubivirus. It's a positive sense single-stranded RNA virus. It has an icosahedral capsid. So here's our genome, here's our icosahedral capsid in green, and it is enveloped. Okay, so it has an envelope with the envelope proteins coming out of it. So it belongs to Baltimore class 4 as a positive sense single-stranded RNA virus. So this has a couple of names for it. It's often called German measles or 3-day measles. If you look at the rash it causes, it's pretty similar to the rash we saw in our measles patients, these small raised red dots on the trunk of the body. And like with measles, it is transmitted via inhalation. So you inhale it, but it can spread from the respiratory tract to other tissues, right? So it goes to the epidermis where it causes this rash, and it can infect other tissues as well. So in most adults, it's actually asymptomatic. So if you caught rubella as an adult, you might have a mild cold, you might not experience anything. The reason that we vaccinate against rubella is not for protection of those who are already born, but it's for protection of the unborn. Rubella can cause congenital rubella syndrome. So our little baby with the congenital heart defects, the cataracts, the deafness, was a child born with congenital rubella syndrome. So this happens when the mother becomes infected with rubella for the first time during the first trimester. So we have an unvaccinated mother who catches rubella in the first trimester. Now, she might not ever have symptoms. She might never know she got infected in the first place, right? And when you're pregnant, you always seem to have some sort of cold or another. So she probably didn't notice. When a mother is infected in the first trimester, 20% of those results in death of the fetus. So there's 20% fetal death rate right off the bat. 85% of live births suffer congenital defects or complications. We read about a few of those in this particular case study. Here's some more: deafness, cataracts, heart defects, brain disorders, mental retardation, bone alterations, so the bones do not develop properly, liver damage, spleen damage, and late onset manifestations of things such as diabetes, thyroid dysfunction, visual or neurological abnormalities. So in a healthy adult, even a healthy young child, rubella is not anything of concern, to be honest. But all of these things can happen to a fetus that becomes infected with rubella. And it's very easy for rubella to cross the placental barrier and infect a fetus. Okay, so looking at the pathogenesis of rubella, initial infection causes replication of the virus there in the nasopharynx, right? Remember, it's spread by respiratory secretions. There in the respiratory tract, an adult at most is going to have a cough, a minor sore throat, nothing else. Young children will have this as well. And then it spreads from the respiratory tract and it can get to the skin. So this is where it's called German measles and 3-day measles, because it has that red rash that looks like measles. Some of these can actually develop into crustier lesions. But these rashes, this is actually due to the immune response, to cellular and humoral immune responses causing death of those infected epithelial cells and inflammation at the site of replication. It can also spread to the lymph nodes. So you can have some lymphadenopathy, some swollen lymph nodes due to it. And sometimes it can actually make it to the joints of adults and young children. And so they'll experience mild joint pain or bone pain, maybe some arthritis, again, due to cellular and humoral immunity. Again, however, it's infection of the placenta or of the fetus that causes the worst set of symptoms. So you can have inflammation of the placenta as well, which is going to decrease blood flow to the fetus, and then all of the different types of fetal damage that I listed on the last slide. So again, vaccination is not to prevent, or not to, vaccination is not to protect adults. It's not to protect even young children who will just have this mild disease. It's to protect the fetus as it's developing. So diagnosis is hard to make clinically because it looks like measles. So to make a significant and definitive diagnosis, again, real-time PCR is the way to go, or serology. A lot of you guys have probably had to have your rubella titers checked before to make sure that you are seropositive, that your vaccine gave you full protection. And if it didn't, you may have had to go get a booster of MMRV to get your antibody levels up where they should be. Like with measles, there's not a specific antiviral. We don't have something that will treat and target rubella on its own. So treatment is supportive. So in a young child, again, if they're having a fever, give them some acetaminophen or ibuprofen to bring down the fever. With congenital rubella, you're going to treat the effects as you're able to. So that could be surgery to repair cataracts or heart defects, any other treatments that could be useful in treating the condition. So like with measles, it's part of the MMRV vaccine. And it's once we started delivering the vaccine, we saw a significant and rapid decrease in the number of congenital rubella symptom cases. We know that we still get decent coverage in the United States of vaccination here. So here we're looking at immunization coverage with rubella-containing vaccines in infants. This was for the year 2016. I have not looked up the latest stats to see if there's any new maps out. But you can see in the US, we're at greater than 90% coverage. So we do still have really good coverage here. In parts of sub-Saharan Africa, there's not good coverage, or we don't have data for it. But overall, worldwide, we're doing pretty good. at this. I'd really love to see these numbers get up to closer to 100 personally. One of the reasons that we have such good coverage is because of a huge push in the 1960s to develop and implement a rigorous vaccination campaign. So in the years of 1964 to 1965, there was an outbreak of rubella here in the United States. There were 12.5 million cases of congenital, or of women infected with rubella. During that span, there were 11,000 aborted pregnancies. So this is both elective and natural aborted pregnancies. And 20,000 cases of congenital rubella syndrome. That in 1 year, that is a lot of cases of congenital rubella syndrome. Because of this huge outbreak, there was this massive push to develop an effective vaccine, to add it to the current vaccine regimen, and that program started in 1969. It worked really quickly, and we got vaccination rates up really, really high. In 2015, we were fortunate enough to declare rubella eradicated from the Americas, so from North and South America. This doesn't mean that we never see a case of rubella anymore, but what it means is it's no longer endemic. There's no spread occurring from person to person, naturally occurring in the Americas. Any cases that we see now are either travel associated, where someone who's not been vaccinated travels to another part of the world where it's still endemic, picks it up then, or it's brought in by a traveler. So someone traveling from another part of the world comes here and is diagnosed with rubella here. So we've eradicated rubella in its transmission from the Americas as of 5 years ago. And I really hope it stays that way. And so the question I always ask after talking about rubella and the astounding number of cases that we had in the 1960s is, do we really want to go back to how things were? With the big push we have to delay vaccination programs or to allow vaccines to be more of a choice and to have more people deciding not to vaccinate their children, do we really want to go back to that now? How would you counsel someone who comes in and says, I don't want to vaccinate my kids. I don't think measles, mumps, rubella, or chickenpox are a really big deal. How would you counsel them to convince them that, first of all, vaccines are safe, and that second of all, it's better for your children and also your future grandchildren to have these vaccines in place? So something to think about. Normally we would discuss that in class. I'm not going to discuss it with myself. Let's move on to our final RNA virus, hepatitis C virus. So in the last slide set, we talked about hepatitis B, which is the weird DNA virus. Today we're going to talk about hepatitis C. There are other hepatitis viruses out there. We're only covering these two. You'll have to learn all the others at some point. Okay, hepatitis C. It belongs to the family Flaviviridae and the genus Hepachivirus. So other flaviviruses of note that you've heard about, because I've told you about them, are dengue virus, West Nile virus, Zika virus. Those are all flaviviruses. It has a positive sense single-stranded enveloped icosahedral capsid, so it belongs to Baltimore class 4. So here's our RNA genome inside this icosahedral capsid, all of which is surrounded by an envelope, and they make very nice electron micrographs like you can see here. So hepatitis C is bloodborne. It's transmitted through blood and bodily secretions. Usually it's the parenteral route, so we see a lot of hepatitis C in IV drug users. Like with Hep B, it used to occasionally be transmitted through blood transfusions. That's not so much an issue anymore, again, because we do a better job of screening blood to make sure there are no infectious agents in them. For hepatitis C, there are 6 different genotypes. so like 6 different strains, and then lots of subtypes within those strains. So it's not a uniform type of infection or virus. There are a few different types that fall into it. And they can establish a chronic or acute infection. One of the things that makes hepatitis C initially somewhat hard to diagnose just based off of clinical symptoms is that it has a very long incubation period. So anywhere from 6 to 12 weeks. So a person can come in with symptoms and may have a hard time remembering back to like what happened 6 to 12 weeks ago. Why might they have gotten hepatitis C virus during that time frame? Okay, so let's look at the different types of diseases that hepatitis C causes. First up, we have the acute disease, the initial infection, what happens after that. This is actually asymptomatic in about 75% of cases. So a lot of people who get hepatitis C, they have an asymptomatic infection, they may clear it or they may progress to chronic disease. Those that do experience symptoms, this will sound familiar. This sounds like hepatitis B. Fever, fatigue, abdominal pain, loss of appetite, and of course, jaundice. About 85% of those who are infected will move on to a chronic carrier state where they're going to have it with them and they're going to potentially develop chronic disease. So this initial set of symptoms or asymptomatic infection will kind of almost seem to disappear for a while. And then the chronic form of disease can develop 10 to 20 years later. And this is when things get really severe, like you would imagine with hepatitis viruses. A person with chronic hepatitis C can develop cirrhosis. They can develop hepatocellular carcinoma. And one of the tricky things about this disease is that the symptoms come and go. So they may experience liver symptoms from time to time, and then they'll be fine for a while. And we can monitor this by looking at those liver enzyme levels, the AST and ALT levels, to see when a person is experiencing liver damage and when their liver is healing. All right, so these two graphs show us acute hepatitis C on the top and chronic hepatitis C on the bottom. And so what we're looking at is the relative value of the different symptoms and the different viral antigens present. So again, we're looking at the time frame of months because the incubation period is anywhere from 6 to 12 weeks. So our person will be exposed. And then what we'll see first start to come up just a little bit is an increase in hepatitis C genome, so an increase in RNA. That tells us that the virus is replicating, and very, very quickly we'll start to see symptoms. So the fatigue, fever, jaundice, loss of appetite, along with our increase in liver numbers and in bilirubin. So this will come up, and if you look, this acute phase can last for a couple of months. Okay, so around 2 months, will start coming down and will resolve. So this is our acute phase. Our immune response, and the green dashed line here, is not that strong, right? It doesn't come up super quickly and go down super quickly. So it's this kind of slow mount until it levels off. It does control our replication, so our hepatitis C levels go down, the RNA levels go down. And while this immune response hangs around for a long time, it does eventually begin to wane years after that acute infection. So for those that develop chronic hepatitis, we're kind of looking at our acute infection here, where we've got our HCV RNA coming up, our increase in symptoms. And in this case, it goes away again after about 2 months. But now we get those, what's the word for it? Those symptoms that kind of come and go. So here we'll have a person who's experiencing some liver distress, and then it gets better, and then it comes back and it gets better, and so on and so forth for a very, very long time. All right. So our immune response stays up. In this case, it doesn't start to wane. And we always have some level of hepatitis C viral RNA in the body. And as you can imagine, this continual fluctuation of liver damage and repair is going to cause, over time, a lot of liver damage. So these patients develop cirrhosis or hepatocellular carcinoma due to death of liver cells because of viral replication, but also inflammation and the immune response to that infection. All right, so we can diagnose hepatitis C. You can look for antibodies in the patient. These are not the most reliable way to diagnose hepatitis C. They're great for hepatitis B, not so much for C. They tend to show us if a person has been infected in the past, but again, that does not necessarily indicate that they are currently infected. And those antibodies can vary wildly in levels and in timing. So we may see that some patients mount that immune response a lot more quickly, for some a lot later. The levels may be below the limit of detection at some times and not at others. So we can look for those, but we need to do that in conjunction with something like real-time PCR for hepatitis C RNA. This would confirm any antibodies that suggest it's a hepatitis C infection. So once you've confirmed that, there are some options for treatment. If your patient is in that acute phase, it may resolve on its own, like in the first graph on the last slide, and your person may never experience any issue with hepatitis C ever again. If it does not replicate on its own, there are a number of choices that you may treat your patient with, and this is going to vary based on other conditions of the patient. Are they co-infected with anything else? Do they have some underlying immunodeficiencies and a variety of other things? So you can treat a person with interferon alpha and ribavirin to control virus replication. There are other drugs like protease inhibitors. So it's a positive strand RNA virus. It needs a protease to cleave its proteins into various pieces. You can treat with polymerase inhibitors that inhibit the viral polymerase. So there's this wide variety of choices that we have now that we didn't have before. And whereas before hepatitis C infection, particularly if it was chronic, was highly fatal, now it's curable in around 90% of cases. So we've come a really long way for hepatitis C infection. There's not a vaccine against hepatitis C yet, so we can't prevent it easily through a vaccine. One of the best ways, again, comes to blood donor screening, right? So all of these hepatitis viruses historically got spread in transfusions. That does not happen anymore because we screen for them and we prevent them that way. So the other ways that you could prevent something like hepatitis C or other bloodborne pathogens from being transmitted, particularly among IV drug users, is to have needle exchange programs so that people are not reusing or sharing needles. And we're going to talk about that a little bit next time and what the consequences of not having needle sharing programs can be. All right, so those are our RNA viruses, a little bit shorter than DNA viruses. Next time, we'll actually have our last viral class. I said that with the last set of slides. I was wrong. Next time, we'll talk about HIV and some AIDS-defining illnesses like Kaposi's sarcoma-associated herpes virus, also known as HHV8. All right, y'all go have a good day, have a good week, and I hope to see you. Pop into office hours, just say hi, just tell me how you're doing, and send me a picture of your pet, okay? Bye.